Thank you very much for joining our third health security dialogue hosted by Global Health Innovation Policy Program at GRIPS. And my name is Hiromi Murakami with GHIPP, Global Health Innovation Policy Program. I will be moderating this session today. Third wave of COVID-19 is getting very serious, and we continue to face unforeseeable future. However, we have domestic pharmaceutical company that develops a drug that is considered to be effective to COVID-19. So we'll be hearing from speakers regarding Avigan or favipiravir development and deployment and what lessons we learned and how we can best prepare for future health crisis and build health resilience. And that is exactly the purpose of this dialogue series. Today, we have invited Mr. Koichi Yamada and Dr. Richard Kaszynski for lessons achieved under pandemic favipiravir deployment. Both speakers have engaged in favipiravir development and deployment. And we'll be having Dr. Kurokawa as a commentator later. And we'll have dialogue and Q&A session in the remaining time. For administrative announcement, please write your questions in Q&A column on the bottom of your screen so that we can address your questions during the discussion or in question time. So let me introduce speakers for today. First speaker is going to be Mr. Koichi Yamada. He is a corporate vice president, anti-infectives business unit division at Fujifilm Toyama Chemical Corporation. He is a graduate of Kyoto University and completed his MBA at Indiana University in the United States. He first joined Fujifilm Corporation, where his main responsibility was in overseas marketing. Since 2012, he has been involved into the development of an anti-influenza drug candidate with the United States Department of Defense funding and took part in conducting clinical studies of favipiravir in the United States. Upon the outbreak of Ebola fever in East Africa in 2014, after several compassionate use cases, he conducted a clinical study on Ebola patients in Guinea in cooperation with the French medical team. He has been working on administration of the above drug to COVID-19 patients since this spring. And we have another speaker, Dr. Richard Kaszynski. He is co-founder and director at Stanford University School of Medicine, Stanford Solution Executive Director at Koto Medical Tower, Tokyo, Japan. He has co-established various favipiravir projects for COVID-19, and he also serves as a senior medical advisor at the Embassy of the Democratic Republic of Congo in Tokyo, Japan. Previously, he worked as a medical doctor at the Emergency Care and Disaster Medicine Center of Tokyo Metropolitan Hospital and as a fellow at Harvard Medical School and Massachusetts General Hospital Department Anesthesia, Critical Care and Pain Medicine. He earned MD from Kobe University and PhD from Kyoto University. And we also have Dr. Kiyoshi Kurokawa. He's a professor emeritus and director of Global Health Innovation Policy Program at GRIPS. He is a member of World Dementia Council and International Scientific Advisory Committee. With that, I'd like to pass microphone to Mr. Yamada for his presentation. Mr. Yamada, please.
Thank you very much, Professor Murakami-san. It is very much honored to be invited to this seminar from the industry side. And first of all, I really have to remind all of the participants, I'm working for Fujifilm Toyama. That's a profit-oriented entity. So, my remark and comment is somehow biased by my employer. So this is kind of COI statement. Otherwise, if I'm regarded as just an infectious disease or viral specialist, that may not be a correct understanding of my position. So today, I really encountered some hardware difficulty in getting the image into this Zoom system. But nevertheless, it really doesn't matter. I have a couple of slides prepared to showing for your clear-cut understanding. But just before talking about comprehensive issue, let me touch on the most hot topic this morning. I guess some of you already accessed media exposure about Abigail's status. Indeed, a couple of months ago, our company filed a so-called new drug application to PMDA and Ministry of Health based on the phase 3 clinical study that was conducted since this March in Japan. And the primary endpoint wise, we believe the result is quite robust and statistically significant. That was why we filed that application 2 months ago. And we really appreciate all the effort made by PFDA and review division. Normally, the new drug review takes, let's say, 10 months to 12 months. But they have did very much condensed work under these circumstances. So, PFDA's review report was presented to the kind of expert committee, and the expert committee was held last night to discuss how to treat this application. And let me give you the conclusion quickly. They cannot decide whether approval is appropriate or may turn down at this moment. They need to see further supplemental clinical data. So that's why they postponed the decision. And I guess today or tomorrow, PFDA will give us more detailed briefing. So at this moment, all I can say is Japanese regulatory authority would not make any decision about applicant status within this calendar year. So that's something hot topic, and I don't want to mislead you. Applicants are supposed to be effective. Never. So Fujifilm Toyama filed a new drug application 2 months ago, and the reviewing process is pretty much condensed. And yesterday, Japanese regulatory authority, that's PMDA, presented its review report to expert committee so that they can make a judgment whether approval is appropriate or not. And the conclusion is they cannot make a decision based on presented data. And they're going to ask us to present supplemental clinical data so that they can see the entire clinical study efficacy one more time. So as of today, Abigan is supposed to be effective, and that's also my belief. But nevertheless, regulatory approval is not given. And media already reported about these things. So I just want to remind all of you, this is a sort of status, and the regulatory issue is something based on the regulatory science. So I really would like to further comment based on my own or our company's own view, but that's nothing to do with Japanese regulatory decision. That's what I want to told you first. Is that okay? Thanks. So let me show you a couple of slides today. The screen is now shared, all of us. Thanks. So I guess, there are 3 keywords to have this kind of discussion today. The first keyword I'd like to present to you, preparedness.
I guess some of you are already familiar with this kind of terminology. However, let me quote very recently, beginning of November, Nikkei, that's a Japanese economics newspaper, held a conference, so-called Nikkei Communicable Disease Conference 2020. And after the conference, they made this kind of written statement. I just pick up a very much useful sentence. So preparedness toward unseen future pandemic is essential. And there's a common consensus. Many of the issues and countermeasures being applied, not only COVID-19, but also other emerging, re-emerging communicable diseases as well. So I guess we have to really think twice. What does preparedness mean? It's not so simple. It is easy to say to prepare in advance, for example, vaccination development or therapeutic solution development, or major medical institute should have some sort of space, or medical resources, medical doctors, nurse, bed, or those kind of equipment would be necessary. Everyone can easily say we have to be prepared well in advance, but nevertheless, everything is under constraint. Budget is limited, and also expertise on this kind of issue. One expert may say that, the other expert may say differently. So these kind of creating consensus among the society itself is a pretty much hard task. Sometimes we call this is kind of insurance premium. I guess, now everyone having insurance against automobile accident. It is sort of automobile owners' responsibility. However, are you agreeing on prepare a bunch of vaccine stock just in case of next pandemic? And maybe vaccine's shelf life is just less than 2 years. So every 2 years, government or private sector must afford that kind of cost. And the same applicable to therapeutic solutions. Unfortunately, infectious disease drug development, from profit-oriented entities' viewpoint, is not attractive at all. Why major pharmaceutical company focusing on, for example, anti-cancer drug development? There is an economical incentive, and even academia would like to touch on that kind of field so that their research work can be rewarded economically. On the other hand, particularly after World War II, Japan is made a tremendously good job to calm down infectious disease. So no one nowadays, talking about seriously this kind of, airborne pandemic issue until the things really happened. So we really have to bear in mind what kind of preparedness would be, necessary and budgeted by the public funding or private funding. That kind of social consensus will guide us, industry, also academia, how much effort and resource should be devoted into drug development, vaccine development, so on, so on. So first things I want to point out is that society's consensus will give us sort of guidance and determine in coming futures what kind of things would be realized. And next point, I really want to raise this issue at this seminar is balancing private and public interest. Of course, public interest is sometimes superior. I respect that from private sector's viewpoint. But let me give you a very concrete example. I guess some of you may had the agreement on trade-related aspect of intellectual property right, abbreviated TRIPS. This treatment essentially allow any country overrule patent rights, more exactly, patent holders' right in light of the public interest. The concrete thing is currently happening is Indonesia. We have effective patents related to Abigan's manufacturing in Indonesia. So patent was granted over 10 years ago and still effective. Very recently, Indonesian government informed the Japanese government they would like to exercise this treatment clause so that Indonesian government-owned pharmaceutical company can produce Abigan, more exactly generic product, without getting any license from patent holder. So this is sort of compulsory license. It's not negotiable just due to the public interest. Indonesia need to produce Abigan generic on their soil. So they would like to claim this is a public interest. Of course, in light of the public interest, private interest may not be so important, may not be so valuable. But once this kind of things happened, how much research work, how much clinical development work would be exercised by the private sector, by the industry? That's really discourage, not only just discourage, harm private sector's interest. And if this kind of right will be abused, any kind of drug or even some evolutionary, innovative or development in any field can be overruled easily by the private interest. So this is something, private company like Fujifilm cannot oppose. This is a sort of talk between government to government. And this pandemic, opened up this kind of discussion. And if Indonesia would become the first country to exercise this compulsory license, I'm sure many countries who has somehow domestic pharmaceutical industry and having a big population will follow this pathway. That means essentially there's no space for particularly Japanese industry to supply made in Japan drug to those countries. So I want to raise the second point. Please think of how we can make a balance private sector and public sector interest. Compulsory license is one of the example, but give us very good, platform how we can really think of in concrete. And third point I want to put on the table today is access to unapproved drugs. So those who are living in Japan having a privilege to have a uniform and very much easy access to any kind of authorized drug under the national health insurance system. That's good things, no doubt about that. But if we enlarge our scope, unapproved drug supply is a sort of common practice under the labels of compassionate use, expanded access, or named patient supply. Those things are governed by rules, but there's, to my knowledge, not yet uniformed standard, globally. Somehow vary country by country. And sometimes, I mean, in Japan, unapproved means is something like, this is not drug. But that's not true. For example, very small population of the particular disease. As I told you before, there is no incentive for the industry to develop the particular drug. But nevertheless, as a kind of, secondary indication or third indication, some researchers may point out that drug might be workable against that particular rare disease. How patient should react under this kind of circumstances? Of course, every drug must be approved and must be listed on the national health insurance system. That argument is, logically correct. But in the real world, always some sort of, untouched or unattentioned area exists. So that's why in Japan, since we are enjoying pretty good coverage of the medical insurance, we may tend to pay less attention to this issue. Access to unapproved drug is, somehow, I feel somehow should be regulated. But on the other hand, flexibly access to any kind of experimental drug might be, taking caring the patient, interest. So I guess I spend too many times. Yeah, I better to stop my word at this stage, and let me pass to Richard Sensei. Thank you very much.
Thank you very much. Please, Richard Sensei.
Okay, there we go. Good morning. Can everyone hear me? Beautiful. Okay. Thank you, Yamada-san, for that wonderful presentation. I think you really kind of hit the nail on the head, so to speak. Some of the key phrases that you just mentioned, such as preparedness or access to these unapproved drugs. These are very important topics. And again, the key theme of today's discussion is education and learning from our experiences. And what we've learned through this pandemic, at least one of the lessons that we've learned, is how unprepared we really were for this. But it's important for us to learn from these experiences and use these experiences to good use for future pandemics as well. So today, I just want to go ahead and describe, is it better, Murakami-sensei, if we hold our questions for now, or is it better to ask Yamada-san our questions right now and then move into the presentation? Which do you prefer?
No, we are asking audience to write their questions in Q&A column. So you can go ahead and speak, and then we will pick up later.
Okay, perfect. So I'll ask my question to Yamada-san later as well. Okay, perfect. So again, good morning, ladies and gentlemen. It's really a great pleasure to speak at the third Global Dialogue on Health Security. And at the outset, I just want to say thank you to Professor Kurokawa and Dr. Murakami for arranging this wonderful session. And also a big hello to Yamada-san again, who is joining this session as well and who gave a fantastic presentation. So given the news regarding favipiravir this morning, I thought it would be a great idea if we could review together the overarching strategy to manage COVID-19 in Japan. And together, if we could explore options to strengthen the existing strategy so we can save lives and reduce the overwhelming burden that is currently being imposed upon our medical infrastructure. So with that said, I think it's always great to start any presentation off with a proper background on COVID-19 and where we stand today. So as of December 21st, we have more than 76 million cases of COVID-19 worldwide. The number of deaths have actually exceeded 1.7 million deaths worldwide today, this morning. The latest statistics that we have, and this is taken from the Worldometer website, is on December 20th, we recorded a daily new caseload of 547,000 patients. So the way we look at things on the global distribution end of the discussion is there's 4 countries that account for approximately 50% of all cases worldwide. The number one nation in terms of the number of COVID-19 patients is the United States, which accounts for approximately 25% of all cases worldwide, followed by India, Brazil, and Russia. Now, when we look at Japan on the global stage, it's good for us to kind of know where Japan stands in all this. In Japan right now, in terms of pure distribution of cases, Japan accounts for approximately 0.25% of all cases globally. And of course, this is probably a data set that you have all seen and you're probably getting tired of, but I think it's important to address that Japan is currently in the midst of its third and most powerful wave of COVID-19. And again, with that, the overwhelming burden that is being currently imposed upon our medical institutions, in particular our ICUs and our ERs, is really getting to a point where it's paralyzing the existing medical infrastructure to a point that we are having to turn away patients who are, for example, experiencing a myocardial infarction, or maybe a cerebral hemorrhage, or maybe some traumas. And really, it's not, there isn't a total collapse of the medical infrastructure just yet, but if we continue this trend, I think that more lives will be lost in the process, and these lives will not only be lost due to COVID-19, but to other conditions as well. And just to give you a background on what coronaviruses are, coronaviruses, there's a common misunderstanding that the name coronavirus was applied to this particular virus because the projections of the virus resemble that of the points on a crown. But the actual original virologists who described this virus back in 1968 actually were referring to the corona of the sun. And what's important to note with regard to this virus is that it's the second most prevalent cause of the common cold next to the rhinovirus, and it accounts for approximately 15 to 30% of all human colds. The virus itself does tend to replicate at lower temperatures, and therefore there's a predilection for upper respiratory tract infections. And there is really no durable immunity, and that's why we see frequent cycles of infection for this particular virus. So now let's actually move into some real world discussions on COVID-19 and where we stand today. And yesterday we had some very sad news about a gentleman in his 60s who had passed away from COVID-19 during isolation at home. And I think this is one case that we could make that perhaps this could have been a preventable death. And I'll go into specifics, but before that, it's important for all of us to kind of have a firm, fundamental understanding of what happens, at least in Japan, what happens when you first start developing symptoms, and what happens if you go to the doctor's office and the doctor's office, you come back with a positive PCR result for COVID-19. And so on the far left-hand side of your screen, let's say you start developing a fever and you get a little concerned. So you visit the clinic, the local clinic, and the local clinic, after a proper examination, tells you, well, okay, it doesn't look like you don't have any significant contacts with people with any COVID-19 patients. Your symptoms are not consistent with COVID-19. So, we'll just say there's no need to do any testing for you. Okay, that's one way to do this. Or the doctor may say, well, you definitely seem to have a history that warrants further diagnostic testing. And also you have symptoms that are consistent with COVID-19. So let's get you tested properly. And then the doctor will escalate you to a proper diagnostic test, whether that be a rapid diagnostic test for antigens or maybe a PCR test. So if you undergo the diagnostic test, your PCR comes back negative. After your symptoms go away, you get to return to school, you get to return to work, you get to return to your normal life, whatever you were doing before you started developing these symptoms. But now, what happens if that diagnostic test, that PCR test, renders a positive result? Well, there's two different sets of fate that await patients who test positive for PCR. One, if you're symptomatic and you're displaying symptoms associated with COVID-19, then you would be admitted to a hospital, one of the designated COVID-19 hospitals in Japan. You can't just be admitted to any hospital. It has to be a hospital with a dedicated COVID-19 ward or an ICU or COVID-19 staff. And so once you're admitted, of course, you'll receive the standard treatment, the standard of care. And at the end of the day, if you meet the criteria of having met at least 10 days, having been passed since the onset of symptoms, and at least 72 hours have passed since the resolution of symptoms, you get to be discharged, and then you get to go about your way. And again, you get to go back to school, you get to go back to work, you get to go back to your normal life after this. But now, what's a little problematic, and which is highlighted by the case that we just discussed right now with the 60-year-old gentleman who passed away during home isolation, is if you're asymptomatic or if you have very mild symptoms, then we don't admit you to the hospital. What you do is we either put you into home isolation or hotel isolation. Now, hotel isolation is a little tricky. There are different criteria that need to be met for different prefectures. For example, Tokyo and Yokohama, although being neighbors, have very different criteria for whether or not a patient meets the standard for hotel isolation. So again, it's a bit tricky in that sense because it's not a uniform criteria for determining whether or not a patient goes into the hotel or the home. But with that said, so if you're asymptomatic or mild, if you have mild symptoms, you wait, and you have to fit the criteria of having at least 10 days being passed since the onset of symptoms, and also at least 72 hours having passed since the resolution of symptoms. Then you get to go home. You get to be released from your home isolation or your hotel isolation. The asymptomatic patients follow a slightly different route of approach. If you're asymptomatic and you're placed in home isolation or hotel isolation, what happens is if 10 days have passed since your RT-PCR test, then if you don't have any progression of symptoms, or if you're not getting worse, and if you're remaining asymptomatic, then that's the criteria for release from your home isolation or your hotel isolation. But now this is a problem. And let's kind of discuss this particular part of the overarching strategy in detail, because this is where, in that news article that you just saw, we lost a patient's life. Now, if we're talking about a patient who is in their 20s or 30s, or maybe 40s, with no underlying medical histories, such as diabetes or chronic heart illness or chronic respiratory illness, then I think the strategy is not much of an issue. But once you start hitting the higher age groups, meaning the higher risk categories, then you have an issue, because we're essentially telling asymptomatic or patients with mild symptoms to just go home or just go into hotel isolation and just wait. And if the patient's symptoms get progressively worse, then to consult the hospital or consult your doctor and determine whether or not you should be going into one of the designated COVID-19 hospitals. But by that time, it could be too late, as we just illustrated with the case of the 60-year-old gentleman in Hiroshima. And I'll give you another example of how quickly symptoms can exacerbate, how quickly symptoms can deteriorate in some patients who fit the higher risk categories. So one great example is the loss of a fantastic ER physician in the United States, Dr. Frank Gabrin. Dr. Frank Gabrin is considered one of the first frontline ER physicians to have lost his life due to COVID-19. And in this particular patient, Dr. Gabrin was, I believe, 60 years of age, but it only took Dr. Gabrin 5 days from the onset of symptoms for this very well-respected physician to succumb to COVID-19 and ultimately die from COVID-19. And, you know, taking that into consideration, and again, we are trying to learn from our mistakes, and we are trying to make the current existing strategy better by learning from each of these deaths and each of these mistakes that we've learned from in the past. And what's important here is to try to introduce something at this stage, instead of just telling people to go into home isolation or hotel isolation and just waiting for things to get worse or better. Wouldn't it be better if we could actually introduce some sort of intervention, you know, whether that be an oral antiviral or maybe some of the antibody cocktails that are being discussed with great interest today as well. And so, you know, if we look at the COVID-19 hospitalization and death risks by age, and this is data that's been published by the CDC, you know, in comparison to what we would consider your normal, healthy, younger population, which is the 18 to 29 comparison group, people who fit the age category of 60, like we did with the gentleman from Hiroshima, have a 4-time higher risk of hospitalization and a 30-time higher risk of death. You know, and with Japan, you have such an elderly population of a very a skewed population that leans heavily towards the elderly. And, you know, in Japan, you'll be seeing more and more patients who have a higher risk, you know, of death in comparison to these younger age demographics by a factor of 90 or 220. And in some cases of having a risk of death that's 630 times as high. And this is, you know, we took into consideration these various risks, and we were trying to come up with some sort of treatment strategy by which we would be able to look at a simple chart and say, well, okay, if this patient fits this general criteria, we should try to initiate treatment as early as possible. And that's what we have here. And this graph was something that we developed through various stages of discussion. And it was Dr. Alex Gadodi who actually went ahead and designed this particular graph for us. But what you can see is this is basically based off of the CDC data that we just observed. So if, for example, you have no risk factors, okay, this is this line here. If you have no risk factors such as diabetes or maybe an immunocompromised status due to, let's say, HIV or AIDS, or maybe you just went through chemotherapy, then, you know, you make reference to this solid line here, the solid blue line. And so, you know, this solid blue line will tell us that, you know, if you're under the age of 50 and you don't have any serious risk factors, then, you know, there's no need to really initiate aggressive early treatment unless you are above the age of 50. And that's when you would start actually experiencing that higher risk of death or hospitalization. The opposite end of the spectrum, let's say you have more than, you know, 3 or more conditions, 3 or more risk factors that would inherently make you a higher risk for hospitalization or death. And these would include diabetes or obesity, hypertension, kidney disease, or, you know, it could also be your ethnicity can also play a part in this risk as well. So basically this is, and I'm running out of time, so I'm just going to go ahead and jump to my next slide. But the main points that we're trying to make with today's presentation is, I think it's important for us to try to optimize the current strategy for COVID-19 management. And in order for us to do that, we need to balance the burden imposed upon an already strained healthcare infrastructure. So this would be a discussion of hospital admission versus home and hotel isolation. What can we do during home and hotel isolation to prevent patients from progressing into more severe categories of disease, or what can we do to maybe even prevent deaths from occurring? There has to be something better that we could do rather than just tell patients to go home or go to a hotel and self-isolate until things get worse. And if that solution comes in a very convenient package like a pill or a single injection, then I think that would be a very viable and economic option, not only for treating the individual patient, but by treating the individual patient and preventing this patient from developing more severe forms of disease. Hopefully we'll be able to prevent hospitalizations, and by doing so, we can help relieve some of that burden that's being imposed upon our healthcare infrastructures. And so, again, there are numerous treatments that are available for hospitalized patients, but a lot of these treatment options that we have in the hospital for hospitalized patients are not the most suitable for an ambulatory setting use. And early treatments to prevent disease progression and long-term complications are really where we should be taking the battlefield. We shouldn't be trying to fight and contain this only in the hospitals. We should be taking the fight to COVID-19 in the community setting, whether that be in the hotel or home isolation, or hopefully in the long term or in the shorter term, we can actually get a drug that could be approved for use in outpatient and a complete ambulatory setting. But again, there are conditions that must be met. Absolute outpatient treatments have to be absolutely safe. They have to be easy to administer. Otherwise, patients are not going to be able to comply with the drugs regimen. And they also have to be scalable. And again, if we could make this happen, the immediate benefits would be improvements to the individual patient outcomes. And at the end of the day, we'll be able to prevent hospitalization, and we could help we can help perhaps dampen the imposition that's being imposed upon the healthcare infrastructures. I'll go ahead and end the presentation there. If there are any questions, I'd be more than happy to answer. And again, thank you, Dr. Murakami, Professor Kurokawa, and Dr. Yamada for your time. And thank you everyone in the audience for listening.
Thank you very much for informative presentations. Actually, I think Dr. Kurokawa, are you? I think he is in, but having problem with the microphone. So there's so many issues laid out by Mr. Yamada, and a kind, detailed explanation by Dr. Kaszynski. There are so many issues, even from my perspective, and simply, please, tell me if I'm wrong, but I see a lot of the situation here that domestic drug is available and have shown some effectiveness, but it seems like a lot of issue for this Avigan to be approved. For instance, we have seen FDA approved several drugs that comes in so quickly to Japanese authority. But why is happening for this Avigan that has so much difficult time getting approval? Is it a more fundamental issue about processes to approve, or is it more something the environment of the clinical testing, how the condition is much more difficult? What is it exactly? Either Dr. Kaszynski or Mr. Yamada, what would be the bottleneck that we can improve for the future crisis? Because if we're not solving this problem, we're going to see the same problem over and over. And we want to, as Dr. Kaszynski said, if the drug is available, some of the patients want to use it, and then to improve their conditions, and then also, mitigate hospitalization, which is to ease the economic and also the health burden of the hospital. So, Mr. Yamada, if you'd like to comment on this.
Okay, Murakami-sensei, thank you very much. You really hit very much delicate points. But let me give you two things. First, you just said some sort of institutional issue may exist. Yes, indeed. In the States, FDA has emergency use authorization. We call EUA. This is not full approval. So approval is approval, but under the circumstance, pandemic circumstance, even though the data may not be perfect, it is sort of balance risk and benefit. If FDA say it is worthwhile to use this drug at the sort of limited condition, they are able to issue EUA. In Japan, there is no similar, institutional systems. So first thing is there is that kind of difference, and Japan have to incorporate something like a EUA system that's applicable not only therapeutic solution but also vaccine solution. As Kurokawa sensei.
Konnichiwa.
Konnichiwa. Good morning. Very nice to meet you. That's
yes.
the first thing. And second thing is, as you say, sort of Japanese environmental things is Japanese healthcare insurance system is so comprehensive and so well designed. That means the volunteer who gonna join clinical study is limited. This is some sort of contradictory issue. I mean, things all kind of medical care covered by the national insurance system. Why I should be in a placebo control study? There is some risk personally. So it's again balance between public interest and private interest. I better to stop my remark. I mean, Kurokawa sensei must know, must have a very good inside view on this issue. Thank you.
Thank you. Thank you, Yamada-san, for the extensive explanation and background earlier. I was just listening, and Richard, his comment, that was good. So I hope this session will be very informative and identifying certain issue and limitation in Japan in particular. So this is kind of all the time. I think the Washington Post, I think, had quoted my comment, I think, in response to Fukushima accident. And when something happens unexpectedly, and so the Japanese government and people in general is a kind of paralyzed what to do. And this is another case from this January, which started the Diamond Princess. So unexpected emergency, what we'll do. So we have to keep learning the things, and I think learning from lessons. That's my comment in general. Any questions or comment by participants?
Dr. Kaszynski, maybe you wanted to ask questions to Mr. Yamada?
Yeah, sure, if we have time. I think the hot topic, as Yamada-san just mentioned, is the MHLW's decision regarding the non-approval status of favipiravir in Japan. And, I won't mention any specific names, but, there's another drug that was granted emergency approval in Japan earlier on in the pandemic. And this drug was granted emergency approval in record-breaking time. I don't think any drug has historically been approved at the speed at which that particular drug was approved. And I'm just wondering, I think the key word here is the lack of evidence, which resulted in the lack of approval for favipiravir. But I'm just wondering, what is the goalpost here? Because when you look at the approval for that other drug, then you wonder, well, why was it that the emergency approvals and authorization were granted at that time, but it seems like the goal is not clear anymore, or at least the goals have changed from that period in time. And it would be very beneficial to researchers, to clinicians, and also I'm assuming to the manufacturers themselves, if the MHLW and these other government bodies that are responsible for approving the drug or making that decision to approve the drugs if they would tell you beforehand, well, this is the goal that you need to meet in order for the drug to be approved. And I think the FDA tries to do so by using different guidelines and engaging in various discussions. But we haven't really seen too much of that with the MHLW. So I'm just wondering, what do you think about that? What do you think would be, at least in your opinion, what was the major difference between that drug and favipiravir from being, what separated the fate from approval and non-approval?
At least in general, I think there's a sort of guideline and also regulation about the safety and efficiency of any new chemical compounds or water medical treatment, because this is a matter of life and death. So that we have a reasonable scientific base to do that, and also the payment, at least reimbursement on this thing for the industry. It is also like universal health coverage is one of the pride of Japan. So that at least government has to be responsible in regulation and also all this authorization. But I think in this kind of thing, I think medical doctor can prescribe this with a different indication. So you can do that. And so that, but who take a responsibility and the payment on this issue? That's always a case in any democratic country. So based on this, based on this all the data and the reasonably science-based data and results, I think physician can prescribe Avigan to this patient in this time. But how the reimbursement system is a different thing. So that's more like a political issue affecting or just making a decision in coming maybe second wave or third wave.
Right. I totally agree. Yeah. I think, I know we're running out of time, but just to squeeze this in there, I think Japan, what we're doing right now is we are using the drug on a limited basis, but under the banner of a observational trial. Yeah. It's not a true approval. When we use Avigan, prescribe Avigan in the hospital setting, we do so under this observational setting. But, of course, this is actually, I think we're just calling it observational use, but in essence, we're using it in actual practice daily. And if I'm not mistaken, I do believe that more than 10,000 patients have received favipiravir in Japan as we speak. But like I said earlier, I think the most beneficial use of an oral antiviral, whether that, or antivirals in general, whether that be remdesivir, favipiravir, or any other antiviral that's out there, is early treatment always is the cardinal rule, because we know, even for example with influenza, it would be pointless to prescribe Tamiflu or these other anti-influenza drugs 7 days or 10 days into your illness, because simply put, it's not going to be effective. I think it's the same argument that we should be following with COVID-19. I think during the first half of your experience with COVID-19, which would be the viral dependent phase of your experiences with the virus, I think that's exactly when drugs like favipiravir would be beneficial the most. And unless we could actually take the fight to COVID-19 in the public setting, whether that be in the home setting or hotel setting, doesn't matter. If we can't do that, I don't think we're going to ever be able to completely relieve this overwhelming imposition that we have currently on our medical infrastructures. If we don't take the fight out of the hospital, we're going to lose the war. And unfortunately, in that war, we're going to be losing lives. And so, I would hope that, we could figure out, under the guidance of the MHLW, what would be the goalpost here for getting drugs approved in the outpatient setting.
I guess you're right, but I think it depends on this kind of unexpected sort of infectious diseases, which you cannot see, and this has become pandemic, and this is sort of fortunately or unfortunately, it started with Wuhan, but it's become pandemic. So that I think I'm really pushing government and I say the public in general, how in this interconnected world, how different countries respond to this pandemic. And I think we could learn from the better decisions and practices elsewhere in the world. I think this is the advantage of this connected world, so we can choose and respond as appropriate. So I think this is a good thing, and also I think I'm also pushing there may be some mutations somewhere, so that we could share all the sequences of this virus, and which make open sources somewhere, so that we could learn and prevent earlier. Yeah. And in fact, this Fuji's avigan has been one of the agents which has been effective, which is a good sign, and that's a great thing.
Right.
Mr. Yamada, do you want to do something? I saw your hand.
Oh, no.
Yes.
I have completed my comment on this issue. Thank you.
Yamada-san, thank you for participating in this session, really. You are the man who really pursued in this area from development and clinical trial.
Okay, we have one question from audience. Ms. Keiko Izushi, she have a question. Did European countries or welfare state manage this case better? This question is for discussion purpose in terms of preparedness and response to the previous perimeter.
Anyone?
Anyone? Or is that addressed to anybody in particular?
No, it didn't address anyone in particular.
Well, at least the flu is coming. I think over the last 20 years, it has been predicted flu is coming sometime soon, and this and that. I think we had a reasonable preparedness in the advanced country, but I think developing country and also like a bit poorer country is in this kind of pandemic. It's a sort of a great sort of burden to the country. And it so happens, I think we have this drug at this time, but I think Japan was in a good position. We had this so avian. But I think this pandemic could be back again, and that is always a history, is a fight of some infectious diseases and human survival.
Yeah, Keiko, I think that's a great question. I don't think, I think nobody gets an A+ in terms of preparedness or the response to the COVID-19 pandemic. I think some countries have fared a little better, and in those countries, I think the common denominator that we see in the countries that have experienced success, let's say, and I use the term loosely, success against the COVID-19, is that you have strong leadership, and the leaders at the top are not afraid to take certain risks, but they understand how serious this pandemic is, and they're willing to put their, whether that be political lifelines or their bureaucratic lifelines, on the table, and put that in jeopardy to take certain measures. That could become political suicide, but those leaders have been strong enough to place human lives above their careers, and I think those leaders should really be applauded for their initiatives. I'll refrain from naming any specific failure countries, but I think everyone has a pretty good idea of what countries have succeeded and what countries have failed.
Okay, so it's been a very good discussion. We probably need more time to discuss more details, but today, unfortunately, the time has come up, and Mr. Yamada has laid out so many issues that we need to consider to go forward, and we'll continue to face these challenges. So we hope to pick up the topics again in the future to discuss further possibility that we can, to tackle this issue. So if anybody wants to say a last word, and if not, Dr. Kaszynski?
I think thanks again to Murakami Sensei, Kurokawa Sensei, and Yamada Sensei, and thank you very much for a very informative session.
Thank you. Thank you for all the participants. It's great.
Thank you so much.
Right. Thank you.
Thank you very much. With this, we are closing this session for today. And the next session we are organizing in January 14th. We will be sending information again, and hope everybody stays safe. And
Right.
at the end of the year, hope to see you back in January.
And Happy New Year.
Yeah.
Yeah.
Merry Christmas, Happy New Year.
Right. Yeah, right.
Thank you very much, everyone.
Thank you.
Thank you.
Thank you.
Thank you.